morning and welcome to the psychiatry grand rounds today. As I know a few folks are still filing in. It's 1, almost 2 after, so we'll go ahead and get started with the introduction. Today I want to give a very warm welcome to Dr. Reid Blackwelder. He is with the Department of Family Medicine, a professor here at East Tennessee State University. He's also the Director of Medical Student Education Division with the Department of Family Medicine, and he is also the President-elect of the American Academy of Family Physicians. While I was scrolling through his awards and honors, I can assure you there is a substantial list, and they're for medical students, residents, and we are very happy to have him. Did want to make just a couple quick announcements before we got started, just to make sure for residents and medical students to call in to get credit for being here. If the CME does not have your phone number, just get in contact with them because they're keeping the list and the attendance now. As well, also please remember the evaluations in the back. They were starting to dwindle a little bit last week, and we just need proof for the GME that we are indeed having our grand rounds. So without further ado, Dr. Blackwelder, thanks so much for being with us today.
Thank you. It's good to be here. I see some familiar faces. Hi. Some of you have seen some parts of this, but you're now different. You're older and wiser, right? Okay, well, there we are. And I guess there is one thing to change on my CV. I didn't realize how old some of these things are, and time flies. I actually am no longer president-elect, and in fact, I'm no longer president. I just finished that run, and now I'm chair of the board. So I get one more year before they put me on a longboat and set me afire and adrift. And you're laughing, but that's what happens after national leadership. You fall off a cliff. So. But I'm honored to be here and to talk with you about some things that are part of what I'm discussing in family medicine nationally in terms of advocacy, which is about patient-centeredness and about team-based care. And there are a lot of different aspects of this, and we could go into many avenues. But I really want to cover a couple of things in particular. And I want you to remember why you went into medicine. That y'all can't say anything. People never put up with me before. Why'd you go into medicine? Please say it. It's cheesy, but say it. Thank you, to help people. Yes, I see. I told y'all that after the first year when you're all enthusiastic, oh my God, to help people, it's like, help people, whatever. But that's why you did it. I want you to become, because we're not very, and then remain patient-centered, because that's really critical. And I want to talk about communication skills. And I love talking with y'all because you understand this, or should understand this better than many. However, I think there's still places for growth. Have to be working on team-based care, and we'll talk a little bit about what that can mean. Talk a little bit about patient-centered, whoa, if I lean down it gets really impressive. Patient-centered evidence, and talk about attitude shifts. How many of you will admit your attitude has shifted a wee bit to the negative over time? Thank you. That's honest people. Yeah, you get a little more cynical. Well, my job here is to give you hope, all right, because this is really what a lot of things are about. Is it happening for y'all? Yeah, oh, I hate that. Huh? You feeling positive right now? Okay, we'll talk later. I love that, though. But it does concern me that it happened so fast. And you didn't even hesitate to say, oh, yeah, I'm getting cynical. So we got to work on this. The essence of patient-centeredness that I think is really important to take from this, and particularly important in psych and primary care family medicine. And it should be in all of our specialties, but I think we have a special bond. And it really is about relationships. It's about long-term connections. And it's about stories. There's also an aspect of social responsibility. We're here at a major training program, an academic center, and we really need to look and see what our country needs, and are we meeting that? And it's about service. This is not a job that one takes because it makes sense, because this job does not make sense. You do this because it's a calling and you can't talk yourself out of it. And that's really why we end up doing this. So it's a very important thing to recognize. We're all about service. And this is a key component I think we forget. It's not really patient-centered until the patient says it's patient-centered. We do a lot of stuff talking about it, and you look around and there are no patients in the room, so we're making a lot of assumptions, and I think we need to be aware of this as we go along. Because our current reality is that so much of what we do is provider-centered. It really is about us when you look at so many aspects, even with, and I call it transformation. How many of you have heard of PCMH, or patient-centered medical home? This is, again, audience participation. It's part of keeping you awake. But okay, not everybody. That's interesting, because this is in everybody's vocabulary now, even nationally with legislators. They're talking about healthcare reform, patient-centered medical home. It sounds good. It's an acronym. We love acronyms. That's some of the transformation, and yet so much of it is still not enacted because access is on our terms. It's who we are, where we are, when are we open, who you can talk with. I don't know about your clinics, but mine has an auto attendant. I hate auto attendants. I'm supposed to have a special key to get me past the auto attendant. It never works. I always get another auto attendant. Press 3 to be ignored longer. Yes. You know, it's just horrid. And yet that's how people communicate now. It's really, I try to call in, I actually sometimes call in a prescription. And I have to sit through the advertising of the flu shots and other stuff they're doing for 30, 45 seconds until I can then finally get the series of other buttons I have to push to do something simple. It makes it so hard. So all of this stuff is not about patients. It's really annoying. And then I put healthcare system in quotes. Some of you are old enough to know who Walter Cronkite was. How many of you have never heard of Walter Cronkite? Okay, at least one honest person raised their hand. So Walter Cronkite was actually back in the days when news was indeed news and people reported things and analyzed it. He was the one who probably first said that we don't really have a healthcare system in this country. It's not about health, it's not very caring, and it's not a system. And I'm afraid that's still current now. He was a newscaster many years ago. This is a serious issue we're dealing with. So as you look at the things that are about us, it's about what we do. And as a family physician, I have the option of doing clinic and or hospital and or call, and there are a lot of choices that are made. And y'all are getting to see that as well as you go through your training. And you probably have similar aspects. You probably have partners who maybe at one time, well, let me just share it. Wilmot, Holston Valley, there was a time we had an inpatient psych ward, and I could get a consult at the time. Now, it doesn't really happen. It's very difficult because there were changes made in what's available. That's, again, very provider-centered, not very patient-centered. We also have ways of getting rid of patients. So how many of you have heard of DINCA? Okay, the context of DINCA. So this is back in the days, back in the older days when we had paper charts. So I'd have these huge, thick charts. And when I first started in Kingston, I'd open the chart and it would occasionally be DINCA, big red, D-N-K-A, boom. And then if you had 3 of those, kaboom, 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 you were discharged. Did not keep the appointment. A DINCA. So I did something crazy. I said, why did they not keep the appointment? And I was told, we don't know. They just didn't keep it. And I said, could we, because I eventually got into leadership somehow, and I said, could we perhaps call? And then you find out, well, my kid is sick, my mother's dying, I forgot, I don't have gas money. It's really poor form to discharge people, things like that. And yet we were doing that routinely. We're not the only ones. So it may not be called DINCA, but there are people. We just got 2 pediatric patients who were discharged from the peds department because they weren't keeping appointments. And there were challenges, but they had travel and other stuff. They lost a 4-month-old suddenly. So it's a lot of stuff happening. So even within our family of teenage care, we find ways to make it about us. I am inconvenienced, therefore you're gone. So it's really challenging what we do. And a lot of us in primary care are limiting our practices. I was the last family physician still doing OB until I got very involved in the politics of medicine in my academy. But a lot of our local family physicians no longer do hospital work, so we become a hospitalist. I have some who don't do call. And that's not right or wrong, good or bad, it just is. But it's a challenge because we're not going into rural areas as much. And one of the goals of this institution is rural primary care. So those of you who are students, how many of you put in your admission request to Quillen that you want it to be a rural primary care something? Okay, a couple of head shakes. No, none of you. Okay, I know you said it, didn't you? Yeah, okay, good. You all say it. And on the admissions committee, because I sat on the admissions committee years ago, they'd say, check, they want primary care. I say, great, what's that mean? I have no idea, just we're supposed to ask. And you check a box. Thank you for laughing. I mean, that really is, we don't know what we're talking about a lot of times, but we know we're supposed to check. So Quillen, rural primary care. The reality is we're not doing as much as we used to. And we need to be very aware of this. This is part of that social mission. And then everybody who looks over what we do are not at all patient-centered. Not at all. I mean, this includes the insurance companies. It includes Federal stuff, state stuff. It involves medical schools, residencies, sorry to say VA. Think about some of the VA crisis in terms of access. That's not very patient-centered. So we're struggling with this all over. This is a real challenge for us. And a lot of what I have to do in medical student and resident education is about checking boxes and not about real outcomes or improvement or even patient-centeredness. It's about what I have to do, and if I don't do it, I'm a bad teacher or a bad physician. Really, really challenging in this regard. Taking the history is really important, but yet nowadays we don't have much connection. I'll be curious to hear from y'all how much connection and time you actually have, because I think it is different than mine, but it's how you take advantage of your time that's really important. In a lot of ways, we only emphasize certain components. So this is part of the challenge for us, is there only some things we look for. So what's important, y'all can't answer yet, social history. What is it you obtain in the social history? Or what is it you present? You're on surgery, and you're presenting about social history. What is it you present? Y'all can answer, go ahead, they're not going to say anything. Smoking, what else? Alcohol, outstanding. How would you like to be known for the substances you use? And that's it. You know, the reality is there's so much more to patients than tobacco, alcohol, and drugs, and yet that's really how we have consolidated the social history in the patients that we talk about. You know, I think there's some real issues with that. We also have lists and templates. I'm assuming y'all are using EHRs, right? How many of you love your EHR? Okay, there's some, see, that's a fun term. You throw that out and it's relative. Because do you love all parts of it? No. Do you love some of it? Sure. I like being on the road and able to take care of some of my patient needs. That's incredibly valuable for me. I love not looking for charts. I can find stuff. Trouble is, I can't find all the stuff because my record doesn't communicate with anybody else's record. So we're still siloed. I can't get, so a patient says, I was just hospitalized. I mean, this happened just the other day. A woman of mine with chronic inflammatory demyelinating polyneuropathy, very common problem handled by family physicians. You know, one of those weird things. She was just in the hospital, was told she had a DVT, and was given a prescription for Xarelto. Okay? She's already had a clot before, very complicated patient. CIDP is essentially like multiple sclerosis. And she emailed me, because I communicate remotely. I don't get paid for any of this. And some people say HIPAA and all this, but she's aware, and we've got signed documents, but this is how she communicates. So I'm on the road. I'm heading to Vanderbilt to talk to a group. And so I'm trying to coordinate all this. And here's the trouble. She was, first, I can't access that information, because it's in the hospital EHR, not mine. Second, I can't get anybody to answer who took care of her, because everybody's on shift work, so nobody knows who she is. Third, she was given a prescription for a good drug, which she could not afford, which required a prior approval. So here's somebody with a clot who's now gone 24 more hours without getting care because nobody bothered to ask. They just said, here's the right treatment. And I couldn't even access that. So I did something crazy. How many of you, let me show you an example of this incredible technology. How many of you have one of these? Use it as a phone. I know, crazy talk, isn't it? It's a texting device, it's an encyclopedia, but I actually called and spoke to somebody. It was great. And we were able to coordinate care. I talked to actually the PharmD in my clinic and said, I need help. I can't make all these calls. I can't get this information. Can you help? She said, absolutely, no problem. So it's about relationships. It's about communication. It's about finding a way to make it about patients. And lists and templates and EHRs are very, very difficult. I believe it's called his story or her story for a reason. Words are very powerful. I think this is something we've forgotten in patient-centeredness. We talk about patient-centeredness, but we do not do stories anymore. We check boxes. We do all this EHR. Most records are crap, including mine. One that gets printed, 7 pages of nonsense. If you ever get a note from me, there are only 2 places where you should look for anything. One is history of present illness, where I free text the story. And the second is my discussion, not the list of problems, because that's just check boxes. It's my discussion of what I'm doing. Those are the only parts of my record that are worth bothering with. I love getting 7, 8-page notes from subspecialists that all read the same because they check the same boxes and the same boilerplate comes out. That's not patient-centeredness. I can't find the nurse's comments that used to be useful to me about patients because they're buried somewhere in a chart behind a checklist that just is a checkbox. It tells me nothing because they're documenting at the end of a long shift. So again, we've lost our way in lots of ways. So how much time do we allow patients to tell their story or we interrupt them and take control? Not long, I heard that, so give me some numbers. 2 minutes. Oh, if only, my God, that would be amazing. How long? 18 seconds. See, you've been listening to me before. I told some of y'all that you've heard parts of this, but it's different now because you're actually closer to being physicians. So hopefully we've got a different perspective. It's actually only 15 seconds. And we'll talk about what I mean by that. But most patients come in and see any provider, and within 15 seconds we take control of the interview. Now, family physicians are a lot better. I don't know about psych, but I know about family docs. How long do we give folks? 20. If only. We give 18 seconds. Yeah, but I mean, that's like 20% more time. I mean, you can get a lot more down your list in 20. Yeah, thank you so much. I'm proud of us. Yeah. So, I mean, the reality is we really take over quickly. And because we feel time pressure, we're being paid fee for service. You're paid for volume, not for quality. A lot of challenges in this. And everybody's looking at your documentation. What we're doing is chart care, not patient care. Everything we check is about billing and an attempt to find you fraudulent. That's probably extreme, but that's really all it's about. It doesn't help patient care in the least. But if you don't do it, even if you say you did it, if you didn't document it, you didn't check the box, I'm not paying for it, you submitted the bill, we've already paid you, you're now fraudulent, we're going to charge you. It is insane. It's insane. So we've got some real challenges here. The interview of patients is really important, and you know this very well. You have to find out about the medical, the psychiatric, the behavioral, all of those issues, and you've got to figure out where your patient's coming from. You know, what is their philosophy of care? You've got to generate rapport. And you're all good at this. You can't get to this level in our profession and not be good at it, but some are better than others. How many of you see someone and you have thought to yourself, they should not be a physician? Okay, so a few hands, the faculty hands went up really quickly. That's because we often see residents and students and go, oh my God. But we also see our partners. And so this is true. There's still differences in this process. Some people are really good at relationship building, some are not as good, and this is really the key. How do you create these relationships and how do you make them last? We've also de-emphasized physical. Now I'm getting a little confused as I get older, and I can't remember with your class. Did your class have more in Bockhorst teaching? Okay, so you're the first class in a long time that actually have physicians teaching physical exams. There was a while here at Quillen where we had standardized patients teaching it, and I would come and tell the first and second year students, hi, by the time you graduate, you will not know how to do a physical. I think that's different now, but it's easy to forget about it. We do labs and studies, though, really easily, and this is kind of what we're doing to substitute. We're moving high-tech, very low touch. I'm concerned about this shift because this changes relationships, and I see it all the time. I'll ask people, so what do you want to do? And we've run through a differential, and they say, we'll do these tests. I said, no, you want to do more history. There are a few things you don't know yet. You'd like to do maybe a physical rather than tests. But this is something that we do. Our current reality in this country is poor outcomes for patients, is poor satisfaction of patients and us. We're not happy with this either, and it's all done at high cost. Take out the provider satisfaction, that's what's called the triple aim in this country. So a lot of things are moving toward the triple aim. I try to refer to the quadruple aim because the providers, the teams, those of us who are doing this also have to be satisfied in a system that's currently failing at all of this. And the partisan politics are preventing change. No matter which side you're on, both sides are at fault, every side's at fault. It's just nonsense. We cannot move forward because of posturing. This is a real challenge. One of the realities, though, is that behavioral health is so important. And a few years ago when I first came to Tennessee, a weird thing happened. I was suddenly told that as a family physician, even though I see a lot of people with depression and anxiety, I couldn't put that down. I mean, I could put it down, but they wouldn't pay me for it. So then I was told the only way to get paid was to write insomnia, fatigue. And that's persisted today, and now even now, because I am a part of helping with mental health, but people will say, well, you don't treat people with mental health problems. I say, yes, I do. Well, you never document it. I said, that's because you don't pay me. It's a real catch-22. And the reality is, I put psychosomatic up there. Many of you would be thrilled if I said, like, Chris, I've got this psychosomatic patient I want you to see. You're fired up, aren't you? Yeah, you are, actually. I like that. But you know, the reality is most of us go, oh, God, no. Please, no. Because we've got this connotation. That just means mind-body. That's all this is. And every patient and every process is mind-body. Everything is psychosomatic. We just forget it. And we carve out behavioral from the physical, and we can't. It makes no sense. So this is our challenge too. How do we work together to pull this back together? Because now whoever's in the system has to be patient-centered, and we do have to define that properly. We need to focus on health and prevention. We need to get away from reactive medicine to proactive care. Because right now we're very good anti-disease. Something bad happens, we're all over it. But we can't keep, we're not putting the energy into keeping those things from happening. We need to be relationship-based, but we've lost a lot of that. We need to be team-based, but we're not good at that either. We still separate things out, and we really don't need to. And we need to use technology well. It's really challenging. Technology is outstanding, but it can't take the place of these other things. It should augment it, and we have to figure out how to do that. We're not very good at it. A lot of it starts with personal choices. So a lot of this is about reframing things. I want you to be patient-centered. I want you to be conscious in your choices of what you do to make this work. This is your practice. This is your style. And I'm going to look at a few of these because I see this as an art class. I mean, this is really you doing what works. You can't do what I do. I can't do what you do. Some of you will have an approach, there's no way I could pull that off. So it's not about finding the one way. It's finding what works for you so that you can sort of have your own masterpiece. Part of this is surrounding yourself with things that are important and nurturing and meaningful. And this is not always that easy. Many of you will get a phone call, because we always get the caller ID, and you look at it and go, oh God, no. Yes, we all have that. Now, if you have somebody who every time they call, you go, oh God, no. I'm going to challenge you, why is that person in your life? Doesn't mean that it's good or bad, but what's going on that you had that? Because I also promise you when you answer the phone, they hear, oh God, no, in your tone. Now, of course, if it's your family member, okay, that's one thing. You probably can't get rid of the family member. You just have to reframe that relationship. But a lot of this is really intriguing. What are the lessons you learn about this stuff? And what can you put around yourself? So this is kind of cool. I tried to do this. When I got in my little suite, I put up Japanese silk screens. So I put those in my suite area to make it look a little different. The kids loved it. One of them became a combination Japanese crayon masterpiece. So that was all right. They weren't that valuable. Then I said, okay, I'm going to put in one of those little Homedics fountains. Those little cool things you get at Walmart that are cheap. Those things are so cool. And then OSHA said, no, you'll give people Legionella. I'm like, what? It says water, clinic, bad. And I couldn't fight that, so I said, okay. You know those fountains are dumb with no water in them? They just don't, they're not very restful. So I said, okay, got to get rid of that. So then I had a patient give me, he was a potter. He was also a former physician, but he was a potter, and he made me teacups. So I said, I am going to serve my patients tea when they come in. OSHA said, no, because we had a little hot thing in the suite. You're going to burn somebody. No, we're not. No one's going to touch it. It's me and the nurse. No. So we moved it to the back, and my nurse, she was so sweet, she would go and still go to the back and bring tea up. And so I'd walk into a room, and there'd be a patient with tea. I'd often take my tea in. I know that's also an OSHA violation, but there's a point where I just said various things. And I just did it. Nothing changes a patient visit like something like that. I even had one patient at the end said, do you mind if I stay and finish my tea? And I said, knock yourself out. I mean, how often does that happen? And this is the kind of thing you can do. You do have to be careful. Not everything works. And I'm not saying do what I do. There are stricter guidelines, and the VA has specific things you can and cannot do. But how can you change what's around you? But you have to be careful with humor. A lot of us put humor up. It's not that funny. It's usually mean. It's usually cynical. It's often against people, things. Be careful about that because other people see it and it reflects something about you. Be sure you're reflecting something you're proud of. So be careful with that. Humor is really tough. Now, generally, children and puppies work pretty well. Kittens are a little harder because, cats are different. They're a little more cynical. Y'all aren't, thank you for laughing. That was, yeah. But what are your images? What are you doing? How do you make this work? Very important. And then what kind of image are you presenting, and is it working for you? So this is fun. I appreciate y'all coming in and listening to me, but I will say over the years, I've often seen people come in and watch their face when they look and see who's in the front. It's a weekend. on a home project. We just had our basement flood. Huzzah. We were one coat of paint from one door away from our downstairs being done. Now all the laminate's up, everything's shot. So going to Lowe's, doing a lot of stuff. You make at least 5 trips to Lowe's on a weekend for any project. So there I am in Kingsport. I'm going to Lowe's. I've got my paint-stained pants, a T-shirt, my hair in a survivor buff, a phone, beeper. I'm walking down the street. I'm doing things like this. How many of you will cross the street to come talk to me? Nobody's raising their, oh, thank you. Well, you know me. You know, that's, yeah. To know me is to love me. So most people will run away because what words come to mind? If you don't know me and you see that happening, what words come to mind? What's that? Something's wrong. Good. Well, that's very nice. What else? Crazy man. Thank you. Yes. Homeless. All of those. Every now and then really nice people say musician. No. But it's not that. You know, and I've got a cell phone and a beeper. So people say drug dealer. And I'm licensed in 2 states to deal drugs, you know. So we make these judgments. I know I can look scary, but I also know that the way I appear does not mess up patients at all, because I know how to communicate, I know how to connect, and it works, but you've got to be aware of it. If it ever bothered patients significantly, I'd have to rethink it. The people it bothers are folks I like to bother, other physicians. I like to tweak things. And yet it's worked. I've been elected the president of a national organization. I've been in the White House. I've been on media. I still have my hair in a ponytail, an earring, and a big beard. Okay, so it can work. I'm not saying you should try that. But the whole point is, I do what I do for other reasons, but it does not impact my patient care. You have to be aware of what are you doing with your patients? Is it working for your patients? Because everything carries meaning. This is really a big part of it. So we have the tools of the trade. We have all these things that we tend to carry all the time. And actually, I have to put smartphones and computers and tablets up now, because that's what we do. We spend most of our time looking at those and not at people. And I have to admit, I'm one of those, and I hate it. I hate it. You know, when I was doing this talking, that was because I had a Bluetooth. I just couldn't see it because of all the hair. So I'm not just talking to myself. I'm actually having a conversation. We all do that all the time. It's really bizarre. You'll be sitting at a table and nobody's looking at each other. You're looking at your phones. So relationships are changing, and I don't, in fact, I know it's not always good. So we have to look at some things. Now, clothes are another thing. So let's say, and I've got students, so you've experienced this, so you come in and you're going to precept with me. So what you thinking? Thinking pretty nice, right? It's a happy face tie, right? So I've got to get y'all engaged somehow. You're just lucky I'm not right in front of you. Yeah, y'all are laughing, you know. So what's at the bottom of the happy face tie? What's he doing? Ripping a happy face in half. So if you're presenting, are you suddenly feeling all that positive? Because, I mean, look at this. The hair, the face, I turn around and look at you, may not be smiling, and you're about to present, and you see Tasmanian devil ripping a happy face in half. So all of a sudden, that's different. This is not necessarily happy. This is not a great tie for children. But it was, it's smiley. The cartoon character. The Tasmanian devil can be scary, so that's not a great tie. So you don't want to do that. So maybe you want to have this tie. Okay, what's that one? It is the Scream. I know. But look at the colors. It's pink, it's purple, it's blue. Awesome colors. I love those colors. It's hard to find guys that coordinate all of that. But it's the Scream. Edward Munch. This is a very expensive painting, by the way. It's 4 in the morning. Back in the days when people rounded at 4 in the morning and wore ties. I know now you're not supposed to wear ties. They carry fomites. 4 in the morning, you're a patient. I'm waking you up to check you out. You see this face and this tie. Oh, yes, that's not good. No, that terrifies people. So we're not going to do that one. So how about, uh-oh, hang on. Here we go. How about that one? I'm not getting the response you normally get. Winnie the Pooh. What does everybody say with Winnie the Pooh? Oh, thank you. That's much better. What was wrong with you? I mean, come on. So, So Winnie the Pooh ties are very cool. They're really great. I mean, everybody, you can't be in a bad mood with a Winnie the Pooh tie. Try it. It just, because what people walking up to you going, oh, it just, you know, you eventually kind of get out of it. So here's the problem. You're going to go to your hospital CEO to demand additional resources to provide your care. You're going to do what I do, which is to go to Harry Reid's office or Boehner's office. I've literally been in those offices. Is this really a tie of power? Is this one that makes the impression that I want to, especially looking this way? No, that's not a good tie, so let's try one more. There, Jerry Garcia. So, different things from different aspects of what you do. How are you appearing to the people you're working with? What image do you want to give? What connection do you need to make? Now, I bought all those those ties. And I realized as I look at them that you have to be aware. Everything you do carries meaning. So how many of you have paid attention to either the clothes or the jewelry that you've worn at some point in your career? Yeah. Joe, what kinds of things did you pay attention to? What were you thinking of when you were making choices about what you were wearing? Okay. They don't reveal tattoos. What else? How many of you did a residency interview? Come on, some of you I know have done residency interviews. Did you choose a particular color or style? Rusty, you're smiling. I know. But you have been to medical school. Yes. Did you? Red tie. Why the red? Bold. Power. Aggression, but not too bad. And you laugh, but there are commercials right now that do this. There was one commercial, I really loved it. It was a little while ago. You had a mom and a dad and a new baby. Mom's sitting in the living room, the dad's rocking the baby, and he starts to come in, and the baby starts to cry as he's walking in the living room. Then he backs out, and the baby gets quiet. And he walks back in, the baby starts to cry. What were they advertising in that commercial? Paint. They basically were talking about the colors of the room will have impacts. These are things we know. So this is something that we can pay attention to in what you do. And even your spiritual icons, all of these things are critical for carrying messages. So just be aware of them. It doesn't mean something's good, bad, but it does mean you have to be aware of the potential impact, especially in your profession. That's being patient-centered. You also need to be attentive to your affect. How many of you are half-full kind of people? Oh, dear. Because I really piss off the rest of you. Because if you're not half full, you're kind of half empty. Nothing wrong with that. It's not better or worse. It's just who you are. But half full can really be challenging in this regard. It also impacts care, but it impacts one's office. So I was, when I was moving up in the academy, I was grooming my partner. Many of you may know her, Dr. Beth Fox, amazing physician. We were very similar in lots of ways. But I have a tendency to say a couple of things, and I say it routinely. It's all good. A common thing I like to say. When I first started saying it, I think I said it when I was kind of afraid that it wasn't really good at all. It just seemed the thing to say, and it got me through it. And over time, I realized, hey, it is all good. So when I say it, I usually mean it. Well, one day, Beth said to me, Reid, it is not all good. And I said, right. We sat down and had a great conversation. We already knew this was the case, but I was half full, she was half empty. Some of my emails can be very flowery, a little too optimistic. And so I realized that I needed to do something. So on my subject line of my emails, after that conversation, I would put down glass half full warning. So that Beth, when she got the email, could look at it and decide on her mood. She could say, no way I'm reading this right now. I'm not in the mood for Reid. And then she'd come back later. Or she would laugh and smile and open it and would get something out of it. So this is really an important aspect. Patients understand your mood. Again, not good or bad. You are highly successful where you are, who you are, as you are now. But this is a half-full warning, so here it comes. Remember, you always have a choice. Today is yours for a reason. The challenges you face are the teachers of the moment. Even the half-full people are going, shut up. Stop. This is really annoying. You're making us look bad. And we are. Thank you for a little chortle there. But this is where I'm coming from. But I have to know it can be a little bit much. You did choose this profession to help people. Here's the problem. Patients aren't at their best when they come to see you. They're scared. They're sick. Something's happening. People do not come at their best to see you. And we forget that, I think, sometimes. And do what you're doing. Laugh some, but not at people. Find things that just laugh and just smile. It's really good to laugh at yourself. I'm an endless source of humor for my own self. And if you laugh at yourself first, you sort of diffuse it when other people try to do it. So when you look at all of this and working with patients, because this is key, because y'all do a lot of this, You're really working on the encounters with patients. And treatments can have a specific effect. Whatever drug you're going to use may have a particular effect. But there's always also a healing effect. I'm a little concerned at something that's being lost with electronic prescribing. And I do it because you're supposed to for meaningful use, blah, blah. But I like my prescription pad, and I still keep it, and I still use it, because when someone comes to see me, there is a big difference between saying your scripts are at the pharmacy and me writing on a piece of paper that I give to my patient something I want them to do. And I'll often write things like, may take a nap, massage, PRN. That means something to people because I'm giving them something, because my treatment has a healing effect, whatever I'm doing. And encounters have it as well. This is really basically the bedside manner. But a lot of patients miss this. We feel we're losing it. We have only 15 seconds. What do we do in this regard? So what you do is you use some skills. And those who've gone to Quillen, in a lot of places you have communication skills. It's a part of a course that we do. My frustration is here at Quillen. We teach it first semester, first year. You're panicked. You've got a lot of other things happening. It's the only pass-fail course in the middle of a lot of basic science courses. And you sort of get it, you sort of like it, you sort of don't, and then it's gone. And all we do every now and then is we ask you to flip the OSCE light switch. Whoop, I have an OSCE. I have to remember to check these boxes, and light switch off, and I can go back to doing regular things. And that's a real frustration, because to me, these are really good time management skills, and they improve connections. And any student who's ever worked with me often will say after watching me in clinic, you really do that stuff, because I do believe it, and it helps me. In fact, I screw up when I forget to be patient-centered in that regard. And these are life skills. You know, we're going to be better with patients than we are with our own families. That's part of the challenge. Because we'll know, the patient will say, wow, you're really upset. And we go home and we go, of course I'm upset, damn it. And you draw the line in the sand with a loved one because you're a human being as well. It seems hard at that moment to say, wow, you're upset, and see where the conversation goes. How many of you have had that moment where you said, boy, I sure wish I had not said that? Yeah, and you know what you could have said, and the key is, can you do that the next time? And it's about these communication skills: rapport, facilitation, agenda setting, information management, active listening, negotiating common ground. These are the basic skills. We're not going to go through all of them, but they're really important clinical skills, and I encourage you to find ways with this and with other techniques to engage completely. This goes against the technology thing. You've got to find a way to stop using the phone, stop looking at it, look at patients, connect, engage. Got to be present. We used to have the opportunity when I had a chart. I knew that chart represented the patient. I could stop for a moment and just say, okay, now I'm going in with this patient. I've got this moment to focus on. Tablets don't do the same thing. The tablet looks the same for every patient. I've got cell phones and things I have to be using all the time. The distractions are huge. So how can you focus on that patient? A lot of this is impressions of the office, of you, of your staff. We've already talked about this. What is the image you're presenting and how's it working? But then a lot of it is, how do you start your interview? So here's a scenario. You're seeing a new patient. Depression is the chief complaint. What do you ask first? So what do y'all ask first? What's going on? That's a good song, by the way. Yeah. What do you ask? Well, I know a lot of you introduce yourself first. And then many of you are going to say something else. What's that? How'd you come to be here? That's a great question. See, y'all are too experienced. I bet if I could watch, though, there'd at least be a few of you say, hey, how are you? Because we do that in this country. And what's the answer? Fine. Always. Hey, how are you? Fine. So why are you here? I'm having crushing substernal chest pain. So you're not really fine, are you? You know, you want to mess with, how many of you love to mess with people at least a little bit? Okay, 2 of you. Thank you. Thank God you're here. You know, so a trick you could try sometime, because everybody does this. You walk down the street, people say, hey, how are you? Fine. So when somebody does that, go, crappy. Because then they have to do something. They have to either ignore you and pretend like they're talking on their phone, or they have to go, oh, God, now I got to talk to them? Jeez. But it'll teach them something. Nothing wrong with that. And in fact, when I pass somebody, if I say, how are you, I'm doing something a little different. I'm making eye contact, and I'm looking at you, saying, how are you? To say, I'm really interested. And in fact, I'll even wait a moment, and if I say that and don't get a response, just in case, because every now and then people have delayed responses. They don't believe someone's really talking. So I'll wait until about here, because sometimes somebody will turn back and say, did you really ask? I said, yeah. That's a way to, I hate to call that messing with people, but it is. It's a way of trying to get people to be present and engage. Because you will ask people, hey, how are you? Nothing wrong with it. What can I do for you? What brings you here? Very important things. You didn't say this, but very soon, how long have you had depression? That happens very quickly. That's the 15 seconds. What brings you in? Depression. How long have you had it? That's less than 15 seconds. You have now decided the thing that's most important for me is how long you've had it. Nothing else right now, just that. This is what we do to take control. We ask closed-ended questions. Instead, and this is communication skills, I try to tell everybody repeatedly and often, your first 3 questions for almost anything, tell me about X, tell me about your depression. And you listen. This is key, you got to listen. Because you already know your next question, you don't have to struggle to figure it out. Then you say, tell me more. Then you already have your third question. Is there anything else about your depression you want to say? Now, this is not ideal in some situations. Someone, you walk in the room, diaphoretic, clutching their chest, falling on the floor. You don't say, tell me about that. Is there anything else you'd like to tell me? That's when you kind of got to jump in. But for a lot of things with people, you have time if you're willing to give it. And it doesn't take longer than the 15 minutes or however long you get. You get a ton of info. When you ask closed-ended questions, patients start to shut up. They start to shut down, waiting for you to ask the next one. And the other big one is about emotion. Y'all really see people with strong emotions. That's a big part of what's going on. It's a big part of what I see as well. And when people are emotional, when they're angry, they're usually what? What's the real underlying emotion when a patient is angry? They're fear, they're afraid, they're scared. That's the only way they can get power back. That's so common. Not 100%, but pretty common. And we click into weird things. We either find ways of disengaging or we basically get defensive because we're humans too. So it's really challenging to do something different. We also go into didactic mode and you start teaching people, talking about it. Information does not overcome emotion. It will not work. You have cancer, but good news, we caught it early. There are a lot of great treatments. I have a fantastic physician. The last 3 patients I've had with this have done brilliantly. And what has the patient heard? They've heard cancer. That's all they've heard. And then you walk in the next day, and then you're frustrated because you have to talk about it all again when you said it yesterday. It's because they didn't hear. It's because you've got to change how you do this. Y'all are really good at this. But even now, you struggle with this part. You're not required to fix anything. You can't fix anything. We've got to figure out a different way of doing this. Validate emotion. You are probably better than most at understanding this. Can't fix it. Don't be sorry about it. You just need to say, this is okay. This is normal. Or maybe it's not normal. We've got to help you with this. Saying you are angry, you are sad works. It sounds silly when you write it out, but it works. And you know what the emotion is. That's the real key. You know what it is almost always. And if not, you seem angry. I think that I'm not angry. Oh, well, your face and these tones. Well, no, I'm actually just really, this is how I process things. I'm interested. And all of a sudden you know more about your patient. So you can't go wrong as long as you know how to work through this. You listen to folks and don't say things like, I understand, don't be angry. Those things don't work. I promise you, you will do this at some point in your career. You'll have a partner you'll see do it. This is people off. Those aren't cool things to do. This is also powerful. I'm sorry you have to deal with that. It's not your fault. You're just saying, I'm really sorry. This isn't fair. This is a difficult thing. And that's a lot of times what people need most. Your ability to be supportive and to handle your own emotions in tough times. Right? It's okay to connect with people. It's okay to have emotions. It's okay to own up to them. You do have to be careful. You don't want the patient being concerned because you're so upset. Because that does happen. They'll, oh, I'm so sorry, doctor. I didn't mean to upset you. So you have to be a little careful about that transference stuff. But you got to be honest about who you are. So a couple of brief questions on a few other things. Evidence-based medicine. This is an important thing. It should inform what we do. But the statisticians are trying to get rid of that variable of the individual response, yet that's the only thing we treat. There really is no such thing as an average patient. And I think we've got to remember this as we look for evidence and as we inform ourselves through our smartphones, as we change our relationship with patients, we need to recognize there is no such thing as an average patient. And that you have to remember to be patient-centered. Now, I may be wrong on this, but I have a feeling there's no great treatment for borderline personality disorder. But here's the good news. You're taking care of a person, and there's always something you can do for that person, or you can at least help them. I don't treat cholesterol. I don't treat hypertension. I don't treat diabetes. I manage those problems in people, But I think a lot of physicians forget this, and they talk about treating hypertension. You treat people. It's very, very different and a lot harder. So the challenge for us is looking at this new evidence in a patient-centered way. We do know patient-centered interviewing improves health outcomes. People are better in outcomes when they get bedside manner. We're now getting some data over the past 2 or 3 years that team-based care, and that is not a one-size-fits-all, can mean a lot of different things. But when you mobilize people together to work for patients, they get better outcomes. We're also addressing patient-centered medical homes, trying to define what it means, but it does change the way we deliver care, and it needs to change the way we pay for it. We have to get away from the fee-for-service, fee-for-volume to fee-for-value. So these are changes that are happening. They're very tumultuous, and people are unhappy because change, we all want change, but we really don't want change that impacts us. We'd rather have it for somebody else, except we really want things to change. We just want to go through it. And we have to challenge our schools to do a better job of meeting the needs of our country in terms of who we graduate. This is a bigger talk, but even the best places, and we're better than most, but we're not as good as others, but even the best are failing miserably at getting enough primary care into our workforce. That's really what we need, but that involves behavioral and mental health as well. There are a lot of ways we have to define and make this work. We don't have this kind of care as a foundation in the country. Basically, we know that patients will do better if they have insurance coverage of some type, and I know you can get into arguments about high deductible, all these other things, but you got to be covered. And then you have to have a routine source of comprehensive continuous care. And in a lot of places that really does mean primary care, but that's also a subject of political discussion. What does that mean? But people need to have a home, they need to have a place, they need to have a relationship, and they need to have a team around to help care for them. This is really key in helping people get right care, right place, right time from the right person. And this is really what it's about. Patients right now get wrong care, wrong place, wrong time. Very expensive, very bad outcomes. It's usually where? ER. Patients show up in the emergency room. Then you're stuck. Then it's reactive. We've got to be proactive. And it is about teams. First and foremost, we're never alone. I was a solo family physician in a town of 1,400 for 4 years. For 2.5, I was the only physician in that town. And there's sort of a badge of honor. I'm a solo family doc. Well, the trouble is none of us are really solo. We're just not. There's always others. In my town, I had a pharmacy, I had a health department, I had an EMS station, I had 2 chiropractors, and I had a physical therapy office. We were a team before we had acronyms. We knew how to take care of folks. But we have to remember how to communicate. Right now, everybody is siloed. They have their own EHRs. We don't communicate. The ER physician didn't call me to tell me about my patient. He didn't call my team to tell me about my patient. They did things they didn't need to do because they felt they were in isolation. We've got to overcome the limits of EHRs that don't communicate. This is nonsense. There's no easy solution. It's all going to be expensive, but this is nonsense. Until we do that, we're going to continue to duplicate care. We're going to give fear-based care. I've got to do this just in case. We're going to give fragmented care, and all of this is bad at every level. And part of it is the separation of the mental health and the physical health is hugely damaging in this country. We've got to find a way to pull it together. How do we work together to manage our patients? So now my challenge is, what are you going to do different? A lot of times I ask y'all to write something down because listening and trying to pay attention is one thing, thinking about something you might do is another. If you actually put it down, that's pretty powerful. So I'll just encourage you, maybe write something down that you're going to do different about becoming patient-centered in some way because you have a lot of control. You don't need a memo, you don't need a congressional act. These are things you control. And I hope you want to do it because you've answered the call to serve. You're here to help people. And you can. This is what we do. You have to take care of yourself. You're good at creating an environment around yourself and taking care of yourself. And this is hard. We're really bad about balance. We're really bad. But we run the risk if we get so balanced that we put our own needs first that it's at another end of the extreme. Again, it's not necessarily good or bad, but there are consequences to that. Some of the consequences we're seeing is that this calling is becoming a job. It's becoming shift work. It's becoming easier to say, not my problem, now I'm out of here. And I got gray hair, so that troubles me just a little bit. I miss that. And what you do and how you appear, how you interact is often more important than the words. A lot of people say the right words, and you can tell they don't mean it. So I want you to think about how you communicate. You can be more patient-centered as of now. I want you to figure out a way to do that. I want you to understand and use evidence, but be careful about it because a lot of it is still disease-oriented and isn't really necessarily about our patients and how we impact our care. And I want you to think about who your team is. Make an effort to communicate better. You know, Jill and I have had a couple of conversations because I'll pick up the phone and say, I got this problem, can you help? And she may not be able to, but she knows someone else. And this is so much easier than sending a task through an EHR. And anyway, my wife was trying to communicate with her daughter-in-law last night, and they were texting back and forth. And I know this is always risky to suggest anything like this to your spouse, but I said, could you maybe call? Because we're walking the dogs at night, texting on tiny phones, back and forth. It's a conversation. You know, can't you maybe talk? And it didn't work, so I shut up. But I thought it was a good idea. So think about that. How do you communicate with people? How do you work with other members of the team? And the bottom line is keeping your heart in your personal art of medicine, because that's what you're doing. So I appreciate the chance to come and talk with you. I hope I stayed more or less on time for you, sir. Certainly available for questions and comments. And I would be curious, because some of you have heard this before, you might hear it again, but is it different after you have some experience? I don't know, because I don't like to keep doing the same old thing. But hopefully some of you, actually I'm going to be rude right now. I can't help myself. What's one thing you're taking out of today's talk? Yeah. Okay, so what are you going to do about that? Good. So how are you going to do that? I like it. Thank you. Those who've never put up with me, you get the right answer, and then I still stand in front of you and say, why? And what do you mean? Because honestly, we're good. You've been trained to give the right answer. I need to know why and where are you and how can I help you move forward. That's my job as a teacher. Rusty, what's one thing you've learned?
Time balance.
And how are you going to do that? How are you going to do that? Yeah, how are you going to do that? That sounds great. I love it. I'm all for it.
Yeah, me too.
All in favor say aye. Aye. Yeah.
I think a lot of times it's kind of coming in prepared and kind of being with the patient.
I love that.
Understanding why we're doing correlation.
I don't think you know how powerful a statement that was you just said. You're going to read the note. I can't tell you how often I'm precepting with a physician, not a student, who is seeing a patient in the clinic, who has seen the patient, who hasn't read the last note, which has really useful information. Like, be sure you ask about, do this lab, whatever it is. It's amazing. Thank you. That's a great way of being present for that patient. You notice I pick on my students because I figure I have a little power there. I'm not going to mess with the rest of you. But I do appreciate everybody's time and certainly available for questions, and you can probably find me anywhere. I look forward to being a part of your journey. So thank you so much.
Dr. Blackwelder, thanks again for presenting. For those of you who weren't here at the beginning, please do remember the evaluation forms. Thank you so much.
Thank you.